Athletic trainer and an assistant professor in the Department of Kinesiology. She received her BA in athletic training from Central College and her Master of Science in Athletic Training and Doctor of Philosophy in Rehabilitation Sciences from the University of Kentucky. The title of her talk today is The Relationship Between Physical Literacy and Physical Activity in Individuals with a History of ACL Reconstruction. For our remote viewers, if you have questions, please submit them using the Q&A function at the bottom of your screen, and our wonderful graduate assistant, Matt, will read them aloud. Or when we do have questions from the audience, we ask Dr. Kleis if you could briefly restate the question for our online viewers. The mic doesn't pick up voices too well. So with that, I will let you get started.
Awesome. Thank you. So before we get started, I do want to mention some acknowledgements. So most of the work that I'm going to discuss today did happen at the University of Kentucky. So I do want to thank and acknowledge them for the financial and other resources that they provided me in order to do the work that I'm going to talk to you all about today. But before we get started, sometimes we in kinesiology forget that not everyone is as familiar with the human body as we are. So I do want to make sure that everyone is aware of what the ACL is, even though it is one body part that does get a lot of press. So it is an anterior ligament located inside of your knee. It is one of your main stabilizers. So when we damage this ligament, essentially we cause excessive movement of your lower leg in relation to your thigh or to your femur. And when we're looking at this ACL injury and subsequent reconstruction, it's a pretty big problem in the United States. It's been estimated that up to 250,000 of these injuries happen every single year. And that reconstructive surgery is the standard of care in the United States, especially for our young, active, healthy individuals. So the bulk of them will go on to get surgery. And the ultimate goal of this reconstruction is to try and reestablish that normal joint stability and hopefully reestablish that normal joint function so they can return to sport, return to all the activities that they want to do. Unfortunately, this is not what we always see after our surgery. So we do see trends of decreased physical activity. So there's a ton of studies that have looked at this, but kind of rough ballpark numbers, only 65% of patients actually return to their pre-injury level of sport. So what they were doing before this injury occurred. And that percentage starts to drop as that competition level increases. So think of this as moving from high school to college, from college to something like a professional sport. We also see this physical activity decrease continue after that sport participation. So when we're looking at young adults and even middle-aged adults who have torn their ACL and had that reconstruction, we see that they participate in less physical activity and they take less daily steps compared to their peers that have never torn their ACL and have never had knee surgery. And this is a pretty big problem. Hopefully we all know the importance of physical activity. If you don't, this is my plug for you. So I've got some images for you here. This one comes from the CDC. So you are recommended to get about 150 minutes of moderate to vigorous physical activity per week because we see all of these benefits. So I could spend years talking about all the benefits of physical activity. So I've just listed a couple here for you. We know that it's good for your physical health. We know that it's good for your mental health. So if we're not engaging in this physical activity regularly, we can start to see some more systemic effects that are just not ideal. So when we're thinking about our ACL patients, obviously this is a problem that we want to tackle. So we have kind of asked ourselves, what is going on here? What is the problem? And most of the evidence that exists about these people focuses on this problem from kind of two camps. So we do have physical problems. We know that these people report increased incidence of knee pain, knee dysfunction. They report decreased muscular strength and endurance. And they also have some biomechanical changes that happen after this injury that affect kind of the longevity of that knee health. We also see some psychological impairments too. So these people report increased incidence of things like injury-related fear. Kinesiophobia just means this general fear of movement. So they might not want to be active because they're scared of re-injuring their knee. And then we also see decreased confidence and self-efficacy, specifically in that knee joint. So we do have some ideas about why these people might not be as physically active, but this doesn't tend to tell the whole picture because we see people who physically they're fine, psychologically they're fine, but they're still falling into this camp of I'm not being physically active. So we need to really start to consider what are some other factors that might play into this scenario. So what I started doing is really diving deep into some of this theoretical literature in realms of public health and realms of epidemiology to try and figure out what are we missing. And when we look at some of these theoretical factors, we can see some of these physical, psychological, but also social and environmental factors that in ACL reconstruction literature right now, we don't tend to look at. We just kind of pretend that these don't exist and we don't focus on them as much as some of the things that I mentioned on that previous slide. So what I really decided to do is to look into a concept called physical literacy. So this is relatively new in the literature, only been really talked about for the last 10, maybe 20 years. But physical literacy is defined as the motivation, the confidence, the physical competence, and the knowledge and understanding to value and take responsibility for physical activity engagement across an entire lifespan. So this concept has been linked to some good things. So we see that if someone is more physically literate, they are more likely to participate in physical activity. We see them also having some of these physical benefits, so increased muscular strength, increased cardiorespiratory fitness, and then we also see improvements in health-related quality of life. So they're just also generally happier, healthier people. However, the problem that exists here is the vast majority of this evidence regarding physical literacy exists in youth and adolescent populations. So we tend to study this from like a physical education perspective, focusing on our youth. So we don't really know what this looks like in adults right now. So really one of the roles or one of the questions that I wanted to tackle is what does this concept of physical literacy look like in individuals, specifically young adults with a history of ACL reconstruction? So in order to do this, I kind of did a two-part mixed method study, if you will. My first part, the goal of that was to really examine the relationship between physical literacy and physical activity from more of that quantitative perspective. So I had my participants fill out patient-reported surveys. I'll tell you more about those in just a second. We had them do some functional assessments, and then we also objectively measured their physical activity by giving them a little monitor that they wore on their hips, and it would keep track of how many steps and how vigorous of activity they were doing throughout the week. And then following that kind of quantitative part, part two was to really qualitatively examine what did these people have to say. So we let our participants tell us about their experiences with physical activity and physical literacy so we can gain a better understanding of what this might look like outside of that youth and adolescent populations. So we did some semi-structured interviews here. But going back to part one, again, we don't have a good idea of what this looks like in adults. So right now we don't have a good way to measure it either. So what I tried to do is utilize some pre-existing measures to hit on those four components of physical literacy. So for motivation, I chose a motivation questionnaire that has been previously validated. For confidence, I chose both a self-efficacy for exercise scale, and then I also wanted to capture their confidence specifically in their knee, since we know this tends to be a problem in this group of people as well. To kind of understand their general knowledge about physical activity, I utilized a previously validated questionnaire to ask them about what they know. And then for physical competence, we utilized a battery of functional tests, two of them. So the landing error scoring system and the single leg hop series we use very commonly after ACL reconstruction. And then the Play Basic is specifically designed to measure physical literacy. And these pictures here give you an idea of what those look like. So this top one is the landing error scoring system. We're having them jump off of a box and jump up into the air while we're watching how their body moves. The single leg hop series, we have them do a series of hops. So one is jumping forward on a single leg, seeing how far you can hop. The triple hop is doing 3 hops, so 1, 2, 3, seeing how far you can hop. And then the crossover hop, you still do 3 hops, but now you kind of cross back and forth over this line. Again, we measure the distance and we compare your legs bilaterally. So how far did you jump on your right compared to your left leg? And then that play basic is 5 movements. So running, hopping, throwing, kicking, and kind of this backwards balance walk. Again, while you're doing these movements, we kind of grade your quality of movement or how competent you are at that activity. So once all of that was completed, we took all this information, we did a stepwise linear regression to kind of figure out which of these factors, if any, are predicting physical activity in this patient population. If you are interested, I have listed some demographics for you. So we did have 45 participants. They were all college age, so kind of mean age 22 to 23 years old. We took all of these variables, we put them into that regression model. I'll show you all the variables in a second, but then we also used age and time since surgery as covariates because we know the older you get, the farther you get away from that surgery, you tend to participate in less physical activity. So we wanted to account for those things as well. So these are all of the factors that we measured. I know you might be looking at these charts going, whoa, that's a lot. So we utilized some Spearman correlations to try and whittle down what variables were actually going to be entered into that model. So we individually looked at how these might relate to physical activity. And we see that some aspects of motivation, so this is what that BREC3 is, and then some aspects of physical competence, the play basic run and the play basic hop were the factors that seemed to be most relevant out of the ones that we chose. We did the same thing for our covariates. Again, you see that age and time since surgery are related to this concept. So we did want to include those in our model. But once we put all of those variables into our model, what we saw is that the play basic run was the only factor that predicted this physical activity. So if you're a stats person, you can see our adjusted R squared. If you're not, what I want you to take away from this is about 13.5% of that physical activity was explained by this variable alone. Again, when we add in those covariates, what I want you to take away from this is the play basic run remained significant. So according to this model, it's still our primary driver, but you see that R squared value or that predictive value go up. It almost doubles. So we do need to take these things into account. This model is basically saying they're not the main drivers, but they're still very relevant that we need to consider. So kind of looking at that first part, what I took away and kind of what I want you to take away is that physical competence, so that kind of single factor, seemed to be related to physical activity in our group. And especially that play basic run, that's more of a quality-based movement. So how are you moving compared to something like a hop test, which is more of an outcome? So when we're looking at these people, we might want to focus on how are you when you're doing that movement and what is that compared to what that total outcome is, because that might give us kind of two different things that we're looking at, where a lot of times after surgery, we tend to focus on that outcome only. Maybe that's not the best way at this point. But kind of leaving part 2, this is a result that I didn't necessarily expect, which is why I was really happy that we built in this second part of allowing our patients to tell us more specifically, what did you experience? What are you feeling? And hopefully this can give us some more insights into this trend. So again, we did some semi-structured interviews, but we utilized what we call a positive and a negative deviance framework. So out of those 45 total participants that we had, we took the 5 most active, the 5 least active. We interviewed them both basically to see, what are you experiencing that's the same? What are you experiencing that's different? So we were hoping to see some differences because this might be where we really learn how can we help these people. So to give you an idea of the questions that we asked, we did have an interview script. We kind of based these questions into 3 different camps. So we asked them about their physical activity before they were hurt. We've got some sample questions for you here on the screen. We asked them questions about their injury, about their surgery, and about their recovery to see that experience. And then we asked them questions about their current physical activity as well. Again, I've got some questions, sample questions that we asked them on the screen. And then I also wanted to give you some information about these people that we interviewed. We could not come up with a better terminology to use, so we called them underperformers and overperformers. So again, overperformers are going to be the top 5, underperformers are going to be the bottom 5. But you do see some significant differences when you look at that p-value. This piece, this daily physical activity and the daily steps, that was by design. That's what we wanted to see. But we also saw that our underperformers were older and they had a longer time since surgery. So this is something that we need to keep in the back of our minds because this might also play into what they're going to tell us. I wish I had more time. This is like my favorite study that I've ever done in my whole life. But these are kind of the higher order themes and the sub themes that we got from those interviews. I have a couple quotes that I will share with you. Unfortunately, I don't have time to share them all with you. So to give you like a really, really brief snapshot of this, we saw a lot of similarities between these overperformers and these underperformers. The main differences that we saw were accessibility to resources. So our underperformers identified this accessibility more so as a barrier. I don't know where I'm supposed to work out. I don't have access to a gym. My neighborhood's not walkable. Where our overperformers identified accessibility as a facilitator. I know where my gym is. It's close. I can walk to it. So this is something in the future we might need to take into account. But really the biggest difference that we saw was the ability for them to establish physical activity as a routine part of their lifestyle. So our underperformers talked about a lot of difficulties, about a lot of the reasons why I can't do physical activity, what's in my way, what's preventing me from doing this, where our overperformers talked about all of the ways that they make this a part of their lifestyle. They talked about most of the same barriers. They talked about most of the same facilitators. So why is one group able to overcome those barriers and the other group isn't? So I'm going to share a couple quotes with you from our participants directly. So one theme that you'll probably kind of pick out that I've identified as a athletic trainer that I think is really important is that transitioning out of organized sport. So even one of our overperformers, someone that was participating in adequate amounts of physical activity, talked about his transition out of football. So he said it just wasn't clear cut. I've always kind of had everything cut and paste for me. And when you're transitioning out of sport and out of high school, it's just like, here's the world, go find it. And it was that perspective that kind of scared me and decreased my confidence a little bit. Another overperformer said, I wish people had talked to me about physical activity not needing to be a high competition or high stress every time. It can be something small that you incorporate into your day. It doesn't have to be an hour-long intense practice every single day. It can be really small, just intentional movements. And I think that shift in my mindset allowed me to not just be quote unquote guilty for not participating in exercise, because I realized that all of the small things I was doing, just setting a little time for myself aside, that was enough. Didn't have to be this big, intense, regimented sort of structure. It was personally my favorite quote of the whole thing. If we have time at the end, I can talk to you about my own experience because I actually fall into this group as well. But what we saw out of both camps is once we actually get out of that organized sport environment, we don't know what to do. And that can be really challenging, right? Theoretically, we're athletes. We know how to move. We know how to participate in sports. But once that kind of social and regimented aspect is taken away from us, a lot of them realize, I actually don't know what I like to do. I've always had someone telling me what to do, when to do it, how many times to do it. So once I'm responsible for that, I just don't know. And that's where we see a lot of difficulties. But kind of looking at that other big theme, so that ability to establish or not establish a routine, one of our underperformers talked about that difficulty. She said, I know it's important. I'll preach on and on about how important it is, although I'm not the best role model. Because she's a student, her curriculum is very difficult. Just with her schedule not being set every week, it was hard for her to find a time. She knew the importance of physical activity. She could just never get in that habit. Wasn't like I was doing anything. It was just not at the top of my priority list. But then we look at one of our overperformers or two of our overperformers. One of them talked about they really started to develop their own physical activity habits, and they feel confident that those are going to stay established kind of throughout the rest of their life. Another said, it's part of who I am, basically. It's part of what I want for my daily lifestyle. So we see these really, really two different stories. And kind of what we took away from this is it tends to be this combination of those barriers, those facilitators, and then knowledge in general. So not only knowledge about physical activity, but knowledge about your new knee health, because unfortunately, you're not the same in most people once you've had this surgery, and that can play a big part of it. And ultimately, what I wanted to take away from this is that physical literacy might be an important factor to consider when we're thinking about our individuals after this reconstruction, because they all talked about aspects of motivation. They all talked about aspects of confidence, how knowledge affected their journey through surgery, through rehab, and into their physically active lifestyles or not physically active lifestyles. And then they also talked about physical competence. So you can think about physical competence basically as your ability to move in different environments and your comfortability doing so. So where do we go from here? The good thing, future research-wise, I think there's a lot of things that we can look at and that we can investigate. So one, I think we need to continue to explore physical literacy in this young adult realm. The methods that I used are not validated. We don't have any tools specifically designed for this population. So I think that's one of the first steps. We also need to think about this big picture, right? We need to think about things like social determinants of health, things like transition out of sport programs, to start to pull in all of these real world factors that these people are going to encounter when they leave high school, when they leave college, whatever realm they were in when they got hurt. Clinically, I don't have a good answer, right? Research-wise, there's a lot that we can do. The big question clinically is how do we prepare our athletes and how do we prepare patients for this physically active lifestyle? And I don't know. If you've ever worked with a 15 to 22-year-old, it's really hard for them to think about what am I going to be like when I'm 30, when I'm 40, when I'm 60. I don't know the best way to kind of get them to see this bigger picture and prepare them for that bigger picture. So I would definitely be open to any thoughts, ideas from the audience. Any questions? And should you be interested, I do have a bunch of resources that I'm willing to share with you as well. Yeah.
Okay, first the stats question.
Oh gosh.
So that first model, you have the adjusted R squared of 27%.
Yes.
That we're leaving 73% on the table.
Mm-hmm.
What the heck's going on? What do you think you need to do to capture another, even just think another 20%, 25% of the variance in your model? Like how else can we explain?
Yes. So the question for the online audience, when we're looking at this adjusted R squared of that kind of covariate model, right, we're missing almost 70%. So what could be in that 70%? I have a couple ideas. So one, I'll say I was kind of blessed overall with a really young, really healthy. While we had people who were not physically active, they all had the ability to do so. So I don't think the sample that I got was necessarily representative of all of what these people look like. So in my sample of 45, knee function was good, confidence about their knee was good. So I do think we are missing some of those psychological components there. But also, I didn't look really at any of these environmental or social factors. And I think that's playing a lot bigger of a piece than what we are giving credit in the literature right now. So I know in the qualitative component, accessibility was a big thing that a lot of people talked about. In this quantitative piece, I didn't look at accessibility at all. So I think we need to consider some of these social determinants of health and in some of these built environmental factors. Is that going to explain the whole 70%? No, but I think it's a start, right? We always look research-wise here. Life is here. So I do think we're missing a lot of those pieces.
So variability in the subject group, subjects.
Yep.
And my second question leading into that, just that part right there, looking at health equity, health disparity, and how that impacts physical literacy. especially the knowledge.
Mm-hmm.
That's things that I've looked at and shared with students, like the knowledge of the person who put up their 115 minutes per week on EPA, so less than 15% of the country adults.
Mm-hmm.
What was your, so first off, what was your subject population? Did they self-identify race, ethnicity?
They did. So question was subject population, essentially demographics. All of them were white except for 2. Mm-hmm.
So then maybe there are some aspects there you're missing, like you said,
Mm-hmm.
social health and health, race, ethnicity, maybe the experience after ACL reconstruction is different
Mm-hmm.
for a person of color versus a white
Yep.
individual. Are there like different patterns in recommendation to perform, right? Recommendation for physical therapy, see an athletic trainer. Is there anything out there talking about that?
Can you rephrase that just a little bit?
Yeah, just so the knowledge, right?
Mm-hmm.
Knowledge and engagement, physical activity, and is there a component of rehab?
Okay.
Right, of populations,
Yep.
color, different referrals, and discussed versus say white or majority.
Yeah. Yeah. So the question was essentially, is there any evidence to suggest that maybe our patients of color are getting different recommendations or different care compared to maybe our white or our more affluent patients? To my knowledge, thus far, I've only read one scientific article really discussing this. And it essentially said that patients on Medicaid get less visits, they get less recommendations. So that's definitely a piece. While you were talking, it kind of reminded me when we're talking about accessibility, I think we also need to think about perceived. So some of my thought process during their interviews was just kind of sitting there because they're all students, they all have access free, thanks to student fees, to multiple facilities on UK's campus. A lot of them have access to free personal training if they choose to do that, but not everyone is seeing that as being available to them. So I think sometimes we're so easy to be like, well, you have this access, but our patients don't always perceive that. They might pick up on some of those barriers. And again, how we investigate that, I don't have a good answer for that. But from the other side, as a clinician, I think those are the questions we need to be asking and hopefully giving them more concrete answers to where to go. From a knowledge perspective, I know that's one of the things you were asking about. My sample, overall, they had really good knowledge about physical activity, right? They knew what they were supposed to do. They might not hit exactly on that 150 minutes, but they knew, oh, like 3 to 5 days, like you want to be in this percentage of heart rate. So that was very interesting. The type of knowledge that was extremely low, though, had to pertain to their surgery, their reconstruction, and their recovery. A lot of them didn't even know what graft type they had. A lot of them only talked to their surgeon a couple times. And we see this in other pieces of literature as well. I think this is a big problem area that we're not giving the patients the information that they need. A lot of them just think 6 months, I'm going to be good as new. And that's not what it is, right? You're going to kind of have this uphill battle. Your rehab should be lasting more than 6 months. And a lot of them don't understand that. And a lot of these pieces are falling through the cracks. They don't even know, am I supposed to get this information from my surgeon? Is it supposed to come from the physical therapist? Is it supposed to come from the athletic trainer? And we're all thinking that another party is going to tell them that. So that information is never getting relayed. And a lot of patients don't even know to ask those questions. So from a healthcare perspective, that's a big issue that we need to fix.
Based on a conversation we've had previously in your time in Kentucky, talking in those rural communities back in the hollers.
Mm-hmm.
So is there a rural versus urban?
Oh,
yeah,
yes, definitely.
Where our department's kind of headed.
Mm-hmm. Yeah, definitely. So question, not really question, discussion point. Now we're talking kind of rural versus urban. Speaking from Kentucky specifically, so when you get into parts of Appalachia, UK is essentially the main healthcare provider in Kentucky. You also have the University of Louisville, but there are patients that have to drive 2 to 3 hours to come see a physician. I know there's a big push there now for telemedicine, but some of these areas don't have Wi-Fi, they don't have access to computers, so that's not an option. So I don't know about you all, like I'm not driving 3 hours to a doctor's appointment, like I just won't go. And I am a healthcare professional, so to expect this from other people is insane. So we need to come up with these other ways. Travel clinics. I know it's really hard to establish a clinic there because people tend to not want to live in those areas. But we've got to come up with some sort of system to get those people the healthcare that they need, because that is a huge, gigantic barrier that most people are not willing to overcome. Because that's an entire day endeavor, 3 hours there, 3 hours back, an hour there. Most people don't have time to do that. So yeah.
Do you have a question online? Do you think any of this applies to post-knee replacement surgery and generally in an older population?
Yeah, so question was, do we think any of this applies in a post-knee reconstruction? Is that what you said? Post-knee replacement, especially in older populations. I think definitely. I think this is a little bit clinic specific, but I know a lot of the clinics that I've worked in order to actually get that surgery, you have to go to a class, basically like a here's what to expect, here's what your recovery is going to be like. I think that's a great first step. And I think in ACL, that's a big thing that we're missing. But again, if we're thinking about an older population, most of them are probably not going to be joining a weekend basketball league, but it's still just as important, if not more important, for them to be physically active. So how do we incorporate activities and social connection tends to be a really big thing that we see in older populations. How do we connect them maybe with physical activity in a social environment so they're getting these benefits that they need? Again, trying to take away some of those barriers. So I definitely think physical literacy is relevant in this different population as well.
So one of the things I was thinking about when you were talking about the barrier, I'm wondering around the excuse making on, well, I don't know where I can go, but that's related potentially to, I know after ACL, I can't perform the way I used to perform. And so I'm just not going to do it instead of be embarrassed or let myself down that I can't do it as much. Is that embedded in here somewhere in the ways you were talking about it? And what role do you see? Because I think about not adolescent, this young adult population and image and what I look like when I go to the gym and what other people see. And that's a huge part of that whole performative part of doing physical activity.
Yeah. So question was, when we talk about barriers, essentially they're kind of other barriers that were talked about. Yes, a very interesting one. Almost every single female in our sample said it. The gym tends to be intimidating, especially if they are trying to do some sort of weightlifting. They talked about, right, we've got big men there that are grunting, that are throwing things, and I feel like I just don't belong. That is a barrier that a lot of our women talked about, which if you're a woman, maybe that hits home for you. And so there are certain spaces I've encountered in certain gyms where there are women only areas. There is unfortunately instance of catcalling there at the gym that got brought up. Again, that's something that as a person you can't always control, but there were a lot of other barriers from a social perspective that were discussed as well. So I moved to college. I'm no longer part of my team. I also don't know anyone. So it's not like I have a friend that can help motivate me because I'm trying to find friends, but maybe this friend that I made is also not interested in physical activity. So I think when we think about ourselves as adults, they're kind of first time encountering, okay, well, no one's telling me to exercise. I have to do it on my own after I've gone to school all day. So I don't really want to go to the gym at 5 p.m. And a lot of them also think that to exercise, I have to go to the gym. So I think a lot of them also are not recognizing walking outside and going for a chat. That's physical activity. So I think there's a lot of this sport reframing that needs to get discussed too. Because the interesting part, a lot of our overperformers were the most critical on themselves. Like, I don't do as much as I used to do. And I don't think they understand what they used to do. So I used to go to practice for 2 hours a day. Okay, well, you were not exercising for all of those 2 hours. And I think they're really thinking about who I was and I need to be that person, and we don't. So I think there's also this mindset shift that needs to change. You're not an athlete anymore. That is okay. You can still participate in physical activity and you can find a new form that's meaningful for you. But that's a hard thing for anyone, but especially young people, to kind of figure out, who is this new me?
That plays into that element of that exploitive nature of sports, of human beings, post-sport world, that if sport is about participation and physical activity and all that. No, sport is a business and the athlete is a commodity within that. And now you're done being able to be our commodity, and now whatever, go on and live your life. That's a really interesting way to think about sport and lifelong physical activity.
Yeah. I think especially when you get into some of these potentially more competitive environments. So college, right? You've got all of these different coaches, and you've got this, in some places, someone's providing your meals for you. So like D1 athletes, they don't even provide their own meals. They just get to go to the counter and the nutritionist has this planned out for them. And I think a lot of what happens is all of that goes away in a second. And now we don't know how to function without all of those supports. So there's actually some interesting literature about the NFL and people leaving the NFL, and quality of life is bad physically and mentally for those people. So I think there's definitely something to that. Oh, thank you all for coming. Thanks to the people in the computer.